Thank you, Dr. Namrata. Thank you for inviting me to this session by AIOS on innovations, and I'll be speaking about a new design of hydrophobic lens, which can be fixated to the capsule. Okay, I'm a consultant to Carl Zeiss, and yes, of course, I have a financial interest in this product because we just got a US patent, and next we'll be looking at commercialization. So as all of you all know, advances in modern cataract surgery have improved results greatly, improvements in keratometry and newer generation formula and optical biometry. However, there can still be patient dissatisfaction because of refractive surprises, IOL tilt, rotation, decentration, PCO, and dysphotopsia. Various capsulotomy fixated lenses are under investigations and are being used. Some of them are the bag in the lens IOL, the lentis laser lens, the femtis IOL from Oculentis, and the masket ND IOL from Mocha. But they have some potential limitations, like removal of OVD from the bag behind the IOL is difficult because many of them fix exactly to the capsulotomy. And you may have to insert them under saline or BSS. Some of them have complicated designs, and it's technically difficult to manufacture. Some need special instruments and injectors. You can also end up with capsulotomy tears, capsular blockade, iris chafing, and pigment dispersion. This is the new design of the posterior chamber IOL. In the phase 1, we tried it out on hydrophilic material with PMMA haptics, and this has been presented, I think, at many conferences, and we also published our initial results in the IJO. Second phase, we went on to hydrophobic material. Initially with the hydrophilic material and PMMA lenses, it used to work well because the hydrophilic material was soft. When we shifted to hydrophobic and used PMMA haptics, the swivel haptics, sometimes we had breakages because the hydrophobic material is harder. So we had to look for new material for the swivel haptics, and we were able to source some material which did not break. That's basically the material they use in spinal surgery. So this is a single piece open loop hydrophobic acrylic IOL. 6 mm aspheric optic, 360-degree square edge, overall diameter is 13 millimeters, very similar to regular lenses. The only difference is that 2 extra haptics are there on the optic at 3 o'clock and 9 o'clock position, made of a proprietary material which can swivel over a pivot. So this is the implantation. So you can see that is the swivel haptic. And then this is loaded into a butterfly cartridge and the regular injector, and you can see it is injected into the capsular bag. Once it's injected into the capsular bag, then you use 2 dialers to just swivel the haptic over the anterior capsule so that it fixates onto the capsule. And then you can remove the OVD also very easily because there's enough space for the OVD to come out. You can use it either in regular phaco, conventional phaco, or with femto cataract. So the size of the shape of the rexus is not very critical. The size has to be approximately 5 millimeters. So here the feasibility of implantation, we checked it on 20 eyes of 20 patients. Mean age was 65 years. We used flax in 4 eyes and manual phacoemulsification in 16 eyes, and all surgeries were uneventful. IOLs of standard powers implanted. The A constant used was 117.4 because this lens sits a little anterior, and mean follow-up was 6 months. Longest follow-up 9 months, and these are the parameters. 65 years mean age, and CDVA was 1. Spherical equivalent was minus 0.46. Axial length 23 millimeters, and normal K1, K2. IOL power on average used was 22.44. And this is the post-op comparison at 2 months, 6 months. And you can see that the uncorrected distance visual acuity was 0.11, and at 6 months, 0.08. CDVA corrected distance vision 0 and minus 0.04 at 6 months. Residual sphere was minus 0.12 and minus 0.16 at 6 months. And cylinder average residual cylinder was around minus 0.71 at 6 months. Spherical equivalent post-op was minus 0.51 on an average. This is the post-op uncorrected distance vision and corrected distance. So you can see that almost at 6 months you had almost about 62% of patients 2025 or better, and all the patients better than 2032. And at the corrected distance visual acuity, all of them had 2025 or better. This is the residual spherical equivalent, and you can see that 16 of the 20 eyes were within 0.5 diopters, and only 4 of them were within 0.75, all of them within 1 diopter. This is the anterior chamber depth measured with the IOL Master 700. There was no significant change at 2 weeks and 6 months. You can see the difference. At 2 weeks, it was 4.35, and at 6 months, it was 4.34. So this demonstrates that the effective lens position is very stable with this lens. The lens does not move. It is fixed to the anterior capsule. So when you put a lens in the back, sometimes the anterior chamber depth can change. The effective lens position of the lens can change over a period of time, and you can have some refractive change. But here, with a capsulotomy fixated lens, it's very stable. And if you look at the ultrasound biometry, the ELP is more anterior and just behind the iris plane. Because of this, again, you hardly get any dysphotopsia because the lenses sit very anterior. This is dilated clinical photography, stable position of the IOL and swivel haptics. There's no decentration, tilt, or rotation. You can see at 2 weeks and at 6 months. And this is post-op day 1, 2 weeks, 6 months, and 9 months. Another case, you can see that they're all exactly at the same position. There's no rotation. So with this, because it's fixed to the capsule, so it's ideal for toric IOLs, irrespective of the bag size. You don't have any rotation. And we also saw that there was no eye which developed PCO at 6 months. We also looked at higher order abrasions, especially coma with the eye trays. Higher order abrasions were not very significant. You can see at 6 months it was just 0.158. Coma at 2 weeks was 0.094, and at 6 months it was just 0.073. Coma is an indicator of tilt. So this shows that there is no tilt and this lens is very stable. And this is again eye tray showing that coma is very negligible, 0.003, 0.006. And we also did serial gonioscopy to see if there is any rubbing of the undersurface of the iris, which can release pigment. And there was no significant increase in the trabecular meshwork pigmentation. You see the photographs at 2 weeks and 6 months. So there's no pigment dispersion. So potential advantages of this lens is it's a simple design, easy to manufacture and pack. Standard injector, you can use a standard injector and inject it through 2.8 mm incision. No special instruments or surgical training required. You can use it either with flax or phacoemulsification. Easy removal of OVD from the capsular bag. Stable fixation, and ELP is very stable. It's got a good centration with no or minimal lens tilt. And for multifocal IOLs, actually with the femto laser, you can design the rexis on the visual axis and then fix the lens so that the lens is centered on the visual axis. So even if there's a large angle alpha, then it does not matter for the multifocal IOLs. And rotational stability for toric designs are very good, irrespective of the bag size. You do not have any rotation. No or minimal negative dysphotopsia because the lens sits anteriorly. There is no pigment dispersion in the study because of the thin swivel haptics. And even if you want to explant this lens, it can be easily explanted if required. You just have to swivel back the haptics and explant it. So to conclude, the new design of IOL, we found it to be safe and feasible, no complications seen at 6 months. good patient satisfaction, no complaints of dysphotopsia, PCO, change in glass prescription. Longer follow-up and larger numbers are required to establish the long-term safety and efficacy. So we just got the FDA approval, and we are looking at commercial production of this lens and maybe a larger study with toric IOLs and multifocal IOLs. That will be the next step to look at the rotational stability with torics and the refraction with torics, and also satisfaction with multifocals. Because with multifocals, the advantages is that you can center it on the visual axis, and since the ELP is more anterior, the effective ad required is less. So if you have less number of rings, then the dysphotopsia and night vision problems also would be less. So this is the lens which I innovated, and hopefully it should be in the market in a couple of years. Thank you very much for your attention.
So thank you, Dr. Sri Ganesh. Again, that was a very useful presentation, and I think towards the end you did answer the questions which are being asked. So the questions that were being asked